Hello, my name is Brendan McKenzie. Thank you for coming to this session. I'm going to be talking today about evidence-based veterinary medicine and the general practitioner. I have no financial conflicts of interest that I think are relevant to this topic. I will disclose that I work for a biotechnology company developing pharmaceuticals to help reduce the impact of aging on the health of dogs. Just a little bit more background about me so you understand my perspective and how I came to this topic. I initially was interested in animal behavior and trained as a primatologist at San Francisco State University. After several years in that area, I switched gears and went and completed my veterinary medical degree at the University of Pennsylvania. I've always been interested in the relationship between scientific research and clinical practice and how science can support clinical decision-making, and that eventually led me to doing my master's degree in epidemiology through the London School of Hygiene and Tropical Medicine. I am, however, at my heart, a clinician, and I've been working in small animal private practice for over 20 years, most of that time at Adobe Animal Hospital, a small animal hospital in California. I have recently also begun to work in the research field, and as I mentioned, I work for Loyal, which is a biotechnology company researching aging in dogs. I'm also a bit of a writer and interested in science communication. So for several years, I've had a column on evidence-based veterinary medicine in Veterinary Practice News, and some of you may know me through the SkeptVet blog and associated social media. This is a platform through which I advocate for evidence-based approaches to veterinary therapies. I will also point out that on this slide there is a URL which will lead you to the SkeptVet website and specifically to a bibliography that I've prepared in association with this lecture that will include both print and electronic resources that I hope will be useful for you. So what is evidence-based veterinary medicine? Well, this is the classic definition of evidence-based medicine generally. David Sackett was the founder in the human field of evidence-based medicine. And I will let you read this for yourself, but I want to highlight some certain elements of it. It is about conscientiously and explicitly integrating what you know as a clinician from your own personal experience and education with controlled scientific research evidence. And we all use scientific research evidence to support what we do in making diagnoses and in making recommendations for treatment for our patients. But oftentimes we use evidence in a haphazard and disorganized way. Evidence-based medicine is simply about structuring and formalizing a little bit the way that we integrate scientific research with our own understanding and our own expertise. Now, there's one element missing from this definition which was added shortly thereafter, and that is that in addition to our experience as clinicians and the research evidence that we rely on, it's important to account for the values and circumstances and goals of the patients. And of course, this is in human medicine. In veterinary medicine, this most often involves our clients. The best therapy in the world with the most robust scientific evidence to support it is of no value if it doesn't fit the resources and capacity and goals of our clients. So this is the Venn diagram for evidence-based medicine. It's simply a bringing together of the clinical expertise that we have as practitioners, the best controlled scientific research evidence that's available, and the needs and goals and capacity of our clients. Peter Cockcroft and Mark Holmes, who wrote the textbook on evidence-based veterinary medicine, added something to the definition which I also think is really important, that in addition to this process of bringing together scientific research and our expertise and our clients' needs, it's about bringing the philosophy of science and the methodology of science to clinical practice. Ultimately, the reason why veterinary medicine is a science-based profession is because science is the best source of information we have available for how nature works, for how diseases are caused and how we might treat them. So trusting in the method and the philosophy of science is a key element to the evidence-based medicine approach. Ultimately, it's hard for us to recognize this, but we are very easily fooled. Our brains make observations and draw conclusions that oftentimes are less reliable than they feel like they are to us. And this leads us into trouble, both as clinicians and also as researchers. So part of the goal of evidence-based medicine is to instill a little bit of self-doubt, to try to get you to think a little bit more critically about how things seem to you and about the probative value of your own experiences as a veterinarian. Mark Crisplip is an infectious disease specialist in the human field, and he has pointed out that oftentimes doing a good job as a clinician, getting the right diagnosis and the right therapy is not so much about what you know, about all the facts you've memorized in your training, as about understanding how you know things and how that process can go wrong so that you can be rigorous and conscientious about using strategies to help correct the errors in your own thought processes that lead to missing diagnoses or to recommending therapies that are not safe or not effective. A slightly more poetic way of putting this, for those of you old enough as I am to remember this book, is that the purpose of science is to help us to be sure that nature hasn't misled us into thinking we understand how something works when really we don't. There are a tremendous number of cognitive biases that can lead to errors in judgment and in understanding of cause and effect relationships, and these are just a few. Cognitive psychology is a robust field that has really helped medicine by helping us to understand how we as clinicians and how we as scientific researchers come to the wrong conclusions and make the wrong decisions. And I think cognitive psychology should, along with philosophy of science, be mandatory for veterinarians because it really helps us to adopt strategies that let us do a better job in clinical practice. Part of the problem is that the ways that we make judgments about cause and effect relationships, about what might be happening with a patient or what might be happening when we apply therapies to our patients, all of those are natural human ways of making decisions and observations that long predate the scientific method. The scientific method is simply a collection of strategies to account for the errors that we make in our own natural observation and judgment. And I use the example frequently of bloodletting because this is a practice that, of course, we all understand today is not a safe or effective medical therapy. But it is a practice that existed and was widely believed to be safe and effective by the best and the brightest minds in medicine for thousands of years in many, many places in the world. This is something that existed and thrived as a medical practice for a very long time, not because people were not as smart as we are or because people were not as educated as we are today, but simply because they had to rely on normal human reasoning strategies, and we have the advantage of having scientific methods to help us correct those reasoning strategies. One example of that is simply the reliance on our own individual experience. If you apply a therapy to a patient and that patient gets better, you're likely to give that therapy the credit. If you do that over and over again, you're likely to be convinced that that is an effective therapy. And that means that when evidence comes along that shows it is not an effective therapy, it's going to be hard for you to change your mind about that. But of course, this is exactly the same sort of reasoning that helped support the practice of bloodletting for millennia. This is an example from Benjamin Rush's book, A Defense of Bloodletting, one of the last vigorous scientific defenses of this practice as it was dying out in the United States in the 19th century. And Benjamin Rush talks about treating his own infant daughter and many other children under 3 or 4 months of age with bloodletting and seeing miraculous recoveries. And to him, this was clear and indisputable evidence that this was an effective practice. And of course, we know now, because we have the advantage of scientific evidence, that in fact is a terrible idea, that draining blood out of infants who are ill is not going to help them recover. But the fact that people did it and saw recoveries was a natural human way of understanding the effectiveness of that therapy. And we make the same kind of reasoning and errors today, even though we have a better perspective on this particular therapy. Another example is that we trust that the practices that we were taught when we were in training and that are part of the history and tradition of our profession must have a sound basis. And so if we have done something for decades or generations in veterinary medicine, it's very hard for us to suddenly realize that that was a mistake, that whatever that practice was not an effective therapy. That, of course, is also behind every therapy that is not safe or effective, no matter what, including bloodletting. People have simply found it too difficult to believe that the best and the brightest in medicine could be mistaken for long periods of time. But that is, unfortunately, the reality. History and tradition are useful guides to what is worth exploring, but are not reliable guides to the safety and efficacy of our therapies or to the causes of the diseases that we see in practice. And finally, we make theories about how nature works, and then we intervene as clinicians on the basis of those theories. And we do this in medicine all the time. Reasoning from basic physiologic principles is one way that we try to make choices about therapy when we don't have, for example, good clinical trial evidence. The problem is that sometimes our theories are wrong or incomplete, and when that's the case, the logical deductions we make from them turn out to be wrong as well. Bloodletting is, again, an excellent example of this. Today, we understand that the spleen is an organ of the immune system and the hematopoietic system, But at the time that bloodletting was practiced for all those thousands of years, it was understood differently. It was understood to be a storage organ for excess blood. And so when the spleen was enlarged, rather than thinking about immune reactivity or neoplasia, people thought, there's too much blood. And they would open the vein of that patient, the blood would drain out, the spleen would shrink down, and if the patient got better, that would confirm in their minds that theoretical rationale. We do the same thing all the time when we make theoretical extrapolations from basic principles, and we have to be careful to realize that without good clinical research, sometimes those theoretical extrapolations simply don't work. This is especially common when we extrapolate from research done in, for example, laboratory animals or humans to veterinary patients. So how is evidence-based medicine useful to you as a clinician in general practice? Ultimately, it provides you with a better source of information, and better information means better patient care. If you understand the true cause and effect relationships between causes of disease and symptoms, or between therapies and outcomes, then you will do a better job of taking care of your patients. And evidence-based medicine helps you to find and understand the best quality of information. It also helps you communicate with clients. If you can say to a client, this is clearly the best choice for your pet because there's strong evidence to support it, that's going to make it easier for you to get compliance with your recommendations than if you have to say, here's something we can try, nobody really knows, or I've tried it before, it seems like it works. That's less compelling evidence. Better information management is actually making my life a lot easier as a clinician, and I think it will make yours as well. We don't think of information management really as part of medicine, but it is. Basically, what we do most of the time in practice is ask questions and try to find answers. We deal with information predominantly. And many of us were trained in an outdated model that we call the just-in-case model. This picture may remind you of veterinary school. We have this idea that you simply memorize all the known facts in the universe so that whenever a case comes in that requires one of those esoteric facts, you have it waiting in your head ready to go. It's not a very efficient information management strategy, and it doesn't work very well in terms of how the human brain functions. A much better strategy is what we call the just-in-time strategy. That's where you are taught the skills to understand what information you need and how to get that information when you need it. It's a real-time information management strategy that's a lot more efficient and a lot less burdensome and a lot less prone to error. Finally, I think there is an ethical dimension to evidence-based medicine. The reality is that we have an obligation to tell our clients both what is true and also the strength of the evidence or the confidence we have in our recommendations. If we want to provide the best patient care, we also have to provide good informed consent. And that means being clear with our clients as to what it is that we are basing our recommendations on. If we are basing our recommendations entirely on clinical experience or tradition, that may be the best information or best evidence we have, but we need to be honest with clients about that, and we need to communicate that uncertainty. Okay, so how does evidence-based medicine work? What's the actual process that you go through? There are a lot of ways to approach this, and this is a fairly simplified step-by-step process that I like to introduce. And I want to emphasize that this is not something that you're going to do constantly all day long with every patient, because that would not be efficient in terms of time or energy. This is a process that allows you to build over time a library of information and of recommendations that you can rely on, that you can trace back to specific reliable evidence and understand the level of confidence that's appropriate to have in those recommendations. So the first thing you do is you ask useful questions. Sometimes we ask general questions that are really hard to answer using scientific evidence, and this method will help you to answer those questions by making them more specific and more focused. And then, of course, you have to find the evidence to answer the question that you're asking. You need to understand how that evidence is useful and what limitations it might have so that you know whether it applies to your patients. And then at the end of the day, you need to draw a conclusion. Ultimately, what we do as clinicians much of the time is make decisions based on what evidence we have. This will help you to make those decisions on the basis of better, more reliable evidence. Finally, and I think this gets skipped often in practice, we want you to assign a level of confidence to your conclusions. You may make a recommendation on the basis of high-quality, repeated clinical studies, and you can have a lot of confidence in that recommendation, or you may have to say to a client, here's a brand new therapy, nobody's really sure if it works, but your pet really needs something, let's give it a try. Perfectly acceptable and evidence-based so long as you are clear about the limitations in that evidence and the unreliability of that conclusion, and you're willing to make changes in your understanding as better evidence comes along. Okay, this is a repeated process. This is something you do over and over again with specific questions and specific issues so that you can build that library of knowledge that I mentioned before. So let's take a case example. This, I think, will make it a little more realistic for you. This is Tallulah. Tallulah is a 13-year-old spayed female Labrador, and she comes to you because she has a gradually progressive hind limb weakness that's been going on for years and getting worse and worse. It's harder for her to stand up, get into the car, get up on the couch, and the client wants to know what to do. And more specifically, they want to know, should they start giving glucosamine to Tallulah? Okay, common question, very common therapy out there. So let's go through how you might answer that question for that client. Start by asking a useful question, right? So this is a scheme called the PICO scheme. There are other ways of doing this, but this is a nice, easy, structured way to think about how you create a question that you can then go to the scientific literature and answer. You want to be specific about what the patient that you're dealing with is or what the problem that you're dealing with is. You want to be clear and explicit about what it is you're considering doing, what we call the intervention, in this case glucosamine, right? You want to be always thinking about what the alternatives are, what's the comparator. So if I ask you if glucosamine is a good choice for this patient, you should be thinking, compared to what? What else could we do and what might be better or not as good? And then finally, you want to be thinking about the outcome. What is it you want to achieve with the therapy that you're considering? So in this case, who's the patient? As I mentioned, 13-year-old spayed female Labrador. She's generally healthy. She's a little bit overweight, big surprise there. And she has this gradually progressive hind limb weakness that's been going on for a long time. You do your exam, maybe you do some imaging, you do a thorough workup, and you come to the conclusion that this is probably caused by some moderate arthritis in both of her hips, right? And ultimately, her role in life is to be a companion to this family. She's not a competition or a hunting dog. Her role is to provide companionship. And that has some impact on the kind of outcomes that we're interested in. Okay, so what's the intervention? Well, we've already said glucosamine. Sounds simple enough, but you know, it turns out glucosamine rarely comes by itself. It almost always comes in combination with chondroitin, and there are a million other things, MSM, green lip mussel, all kinds of things that it could be mixed with. So you have to say, if I'm going to go to the literature and ask whether glucosamine is a good choice for Tallulah, what exactly do I mean by that? Are we talking about pills, capsules? Are we looking at one of any of a dozen specific products? And is there evidence that will help me distinguish between the value of all these different choices? So oral glucosamine and what else? And then what's the comparator? And I always tell people the first alternative to any therapy you're considering should always be no therapy, right? Now, that doesn't mean you're going to choose that, but you should always at least consider what happens if I don't offer a therapy, because it is not always necessary to offer a procedure or a medication in order to solve a clinical problem. Now, I don't really mean do nothing, of course. I always mean educate the client. If there's a reason why, for example, an animal with a probable viral infection should not get an antibiotic, it doesn't mean you simply say, I'm not going to do anything. It means that you explain why an antibiotic would not be to benefit that patient and would in fact potentially be more likely to cause harm. So in this case, is glucosamine a good choice compared to nothing at all? That's one consideration. Or to other therapies that we might offer for osteoarthritis in a dog like Tallulah. I mean, obviously she's a little overweight, so offering weight loss as a therapy is really critical for treatment of arthritis. Lots of analgesics, NSAIDs are the most common, but there are others available as well. Or lots of other therapies. There are many things available, physical therapy, chiropractic, massage, acupuncture, lots and lots of choices. And when you're asking the question, what about glucosamine for this dog, you should always be thinking, compared to what else? And then finally, what outcome are we looking to achieve? As I mentioned, Tallulah is a companion, right? So the level of function that she needs is going to be different than a dog who is a working police or search and rescue dog or a hunting dog, right? So a therapy might be appropriate in one case for a certain level of function, but might not be appropriate in another case if we're seeking a different outcome. If we need a dog who has to be capable of very aggressive activity, total hip replacement might be more appropriate than something like glucosamine or an NSAID. So thinking about the outcome is really important to looking at the research literature and deciding whether this is the therapy that you want to offer. So here is the sum total of our PICO process. We have Tallulah, and we understand who she is and what her context is. We are considering oral glucosamine plus chondroitin, and I simply include that as the main intervention of choice because it's almost impossible to get glucosamine alone anyway. Nothing is another possibility. She has mild arthritis and she's relatively functional, so we might simply focus on not offering a therapy, or we might discuss something like weight loss that isn't a medical therapy. Or she might be severely enough affected that we consider pain relief, in which case NSAIDs are probably the first choice. So we will consider glucosamine and chondroitin compared to either no therapy at all or compared to an NSAID. And then finally, what is our goal? The patient's owner basically wants her to be comfortable, not to have any pain, not to have visible lameness. It's not necessary for her to have a high level of function. So that's the outcome we're shooting for here. All right, so we've said about asking a useful question. Now let's go find some evidence to help us answer that question. How do we do that? You've probably seen some version of this before, the evidence pyramid, and this is a very detailed academic version, probably not super useful to you, but the reason evidence pyramids were invented is simply to show that different kinds of evidence are available, and they differ in two important ways. One, how available they are. Some kinds of evidence are much easier to come by than others, and also how reliable are they. Some kinds of evidence are a lot more reliable than others. So in this case, the pyramid simply says at the bottom is the most available, easiest to come by evidence, and also probably the least reliable. And that usually consists of observations or opinions or clinical experience. At the top of these pyramids is some kind of evidence that is probably the most reliable, but also that there's not as much of, often hard to come by. I've created a simplified version of this, which I think is more useful for those of us in general practice. And this basically says the bottom level of the pyramid is, again, very easily and readily available evidence, but relatively low reliability. And this is just opinion. My experience, your experience, the experience of our professors in vet school and what they told us based on their own personal observations. Easy to come by, easiest to just ask the vet next to you at the table in the office, but not the most reliable. Going up, you have expert opinion. We place a lot of emphasis on expert opinion in veterinary medicine. We really rely on smart individuals to tell us what to do a lot of the time. But we have to remember that individuals are subject to that level of cognitive bias that I talked about before, regardless of how experienced or intelligent or educated they are. So expert opinion ultimately is just opinion. And it's only better than the opinion of anyone else if those experts have perhaps more familiarity with the evidence in a particularly narrow subject area. So expert opinion, still pretty low level. Then there's what we call the primary literature. This is the meat of it. This is all the individual studies. Really useful source of evidence. Often a lot of work to get to and a lot of work to dig through and understand. And so I don't think we place nearly as much emphasis on the primary literature as practicing clinicians compared to academics because we're pushed for time. We need something that is efficient and easy for us to use on a day-to-day basis. So that's where I come to what I call the synthetic literature. This is scientific literature where other people have gone through the primary literature and done the work of finding information relevant to particular questions and appraising that information, looking at it critically to see what its strengths and weaknesses are. These are things like systematic reviews, clinical practice guidelines. I'll go through what this is in a little more detail in a second. But this is the most useful for me as a day-to-day practicing clinician, and also, unfortunately, the least prevalent and the hardest to get to sometimes. Okay, so what is synthetic literature? As I mentioned, clinical practice guidelines. So oftentimes, for example, the American Animal Hospital Association will put together a guideline on treatment of pain in animals, and they will give you a set of suggestions based on the research literature. The ACVIM also has consensus statements, which are very similar. Experts will sit down and go through the research literature and will give you recommendations. These are super useful, efficient things for those of us in general practice to follow. You have to be a little bit cautious because not all clinical practice guidelines are truly evidence-based. There are what we call GOBSAT guidelines, which is just a funny way of saying good old boys sat around a table. That means that a handful of experts sat down and basically turned their opinions into a clinical practice guideline. Still a useful document, but not really synthetic literature, more like expert opinion. So when you look at a clinical practice guideline, just pay attention to whether or not the guideline is explicit about what the evidence says about each of the recommendations they make and how reliable that evidence is. Systematic reviews are a really useful kind of synthetic literature. This is where someone goes through all the primary literature, all the research studies on a particular topic, and they have a very structured, systematic way of doing this so they don't miss anything. And then they appraise the quality of that research literature, throw away the studies that are probably not reliable enough to make any conclusions on, and then give you a summary of what the rest of the evidence says. What is the best evidence on this particular topic? Really, really useful. Big problems with this are, one, they don't exist as often as we'd like them to in veterinary medicine. And two, sometimes there is not enough primary literature to make a good quality systematic review that tells you what you really want to know or need to know to make a decision in practice. But when these exist, they're really useful. Not 100% free of opinion or bias, but pretty darn good. Narrative reviews are a little different. We have a lot more of these, and I've written quite a few of them myself, but I always want to point out that a narrative review is not a systematic review. A narrative review is an individual or a handful of individuals sit down, go through the scientific literature relevant to a particular topic, and give you their interpretation of what it says and what it means, with perhaps some commentary on the strengths and weaknesses of that literature. But they don't use an explicit, formalized, systematic method of finding literature and of appraising that literature. So it's really more of an opinion, but an opinion backed up with citations to the literature. It's a little bit more prone to bias, still often a very useful way for me as a general practitioner, for example, to get a summary of what experts in a field or in a subject area that I don't know enough about think, and that is useful. But it's a little more like expert opinion than it is synthetic literature sometimes. Critically appraised topics are like mini systematic reviews. They do the same thing. They ask a relatively focused question, and they appraise the literature relevant to that question in an explicit, formalized way, but they also typically ask very narrow, small questions and look at a much smaller subset of the scientific literature. Really, really useful for particular topics. Some risk of bias, but pretty good. And then, of course, there's the primary literature. And as I mentioned before, this is the meat of it. This is where most of the evidence is. And if you have the time and the training and the expertise to go through different kinds of study designs and the different kinds of statistical methods that were used and appraise those things and then apply them to your patients, that's fantastic. Most of us don't have the time or the expertise to do that. And so sometimes the primary literature can actually be a little misleading. You may find one study and read just the abstract or the conclusion and come away with an idea about a subject that actually is contradicted by half a dozen other studies that you don't know about, or by better quality studies. And we'll see that with the example of Tallulah in a second. I want to talk a little bit about the use of human medical research in making decisions about veterinary patients, because this is something, of course, that we do all the time in veterinary medicine. Frequently, we find that there is no specific research available regarding a problem in our patients, but there turns out to be research available on that problem or on that therapy in human medicine. And the pros of the human literature are that it is often much larger than the veterinary literature. As we'll see when we look at the research around glucosamine, for example, in arthritis, there's a tremendous, huge literature involving thousands of people in long-term studies in human medicine, and a much smaller and less reliable body of literature in veterinary medicine. It is also often much better quality. The length of studies, the size of studies, the methods used are usually much better in human medicine because the available resources for doing those studies is much greater. Unfortunately, the cons to the human research literature is that it's not always clear how applicable it is to our patients. Of course, dogs and cats and humans have a lot of similarities in their biology, but they also have some differences, and those differences can be really important. So we have to be a bit cautious. We cannot ignore the human research literature because it is voluminous and high quality and often very useful and sometimes the best thing that we have, but we do have to be really cautious about the extrapolations that we make. And then, of course, there's opinion. Expert opinion and my opinion, your opinion, everybody else's opinion. Opinion is not a bad thing. Opinion is simply one level of evidence that we have available and that we may need to use in order to make decisions. But we need to remember all those cognitive biases and all of the reasons why, as much as my experience as a doctor makes me feel like I know the answer in some cases, that experience is not as reliable as good quality controlled scientific research. So finding the actual evidence, once we've decided what evidence we need, can be a little bit tricky. As I mentioned at the very beginning, this is a link to some resources that hopefully will help you with this, that you can find on my website after the lecture. I have also listed here a few of the places that you might go to find research evidence. I'm not going to go through them in detail because we could do an entire course on searching the scientific research literature. But there are a number of databases for research in both veterinary patients and human patients, as well as preclinical research. Lots and lots of places where you can find synthetic literature. The Royal College of Veterinary Surgeons, for example, has done a wonderful job of creating some evidence-based medicine resources. Also, the Center for Evidence-Based Veterinary Medicine at the University of Nottingham has a database of systematic reviews, a collection of critically appraised topics, lots of resources out there to help you, and the link there will lead you to a list of some of those resources for you to explore. Once you've found research evidence that is relevant to your question that could help you to make a decision, the next hard part is getting it. Unfortunately, not all published research evidence is free and readily available. So a lot of us who are not in academia and don't have access to a good quality university library can have a hard time finding a research paper that might be very important in informing our choices for our clinical patients. This is a list of some ways that you can potentially get to the literature if it doesn't happen to be readily accessible. Good old Google, you'd be surprised how often individual scientists will make available copies of their research articles on their own personal websites or on places like ResearchGate or some other scientific website that lists publications. Everything that I write and publish always is available on my websites and on places like ResearchGate. So sometimes simply searching for the article that you're interested in will lead you to it. You can obviously subscribe to individual journals, as I do, or be a member of your association, the AVA, or in my case, the AVMA, do have journals, and membership can help get you access to the scientific literature. You can also share those subscriptions with your colleagues, and frankly, I find it useful to make some friends in academia so that you know people who have access to a good university library, and they can often help you to get those articles that are just hard to get through any other way. I will mention, without endorsing, what I jokingly call the dark web. There is a website called Sci-Hub, which is essentially a copyright violating resource that makes available copies of journal articles that are otherwise hard to get. I don't endorse this, but I will say that it is commonly used in practice by scientists and by clinicians. So we're at the next step. We've formulated a useful, answerable question. We've gone to the literature and found the evidence. Now we have to decide whether that research evidence is actually applicable to Tallulah and how reliable it is. Okay? Critical appraisal. Most of you have probably been in the practice of medicine long enough to know that not everything that shows up in a journal article is true or is useful or believable when it comes to trying to make decisions for your patients. So you need to do some sort of critical analysis or appraisal, grading the evidence. And there are very, very complicated and involved ways that you can do this. There are a lot of things you can learn about how research studies are designed and conducted, about how statistics should be done in those studies. Again, a lot of work. I went and did a master's in epidemiology specifically so that I could get good at this because it really required a lot of formal training. Not something that most of the time we have the time or resources or inclination to do in practice. So again, I usually encourage people to rely on this basic structure, to think about whether the resource you're looking at is your opinion or some other general opinion, whether it's expert opinion, whether it's a primary research study, which, as I said, is often the hardest to make sense of, or whether it is some form of synthetic literature. Okay, so for Tallulah, we've gone through this PICO scheme. We understand who our patient is. We know that we're thinking about giving her a glucosamine chondroitin supplement. We're considering that as an alternative to not doing any medication or to doing something perhaps more aggressive, like an NSAID. And our goal is for her to have negligible pain and no lameness or good quality day-to-day pet function. So let's go through the literature and see what's available. Starting with the best quality evidence, the synthetic literature, let's look and see if there are any clinical practice guidelines that will help us. Unfortunately, no. There are no veterinary clinical practice guidelines that will specifically address the question of whether oral glucosamine and chondroitin is an appropriate therapy for Tallulah, for an older Labrador with osteoarthritis of the hip. What about systematic reviews? Yes. In this case, we do have some systematic reviews that answer this question for us. And there are 3 of them, which is a little bit unusual in veterinary medicine. If you look through these reviews, you will find that most of them evaluate only 1 or 2 primary research studies. And that's because that's all that there was at the time that these systematic reviews were done. The most recent, in 2012, only had 2 clinical research trials to review. So as I mentioned before, systematic reviews are a great way to look at the quality of the research literature in a systematic and comprehensive way, but unfortunately, there may not be much research literature to look at, and that can weaken the conclusions. So in the case of the most recent systematic review, where there were 2 studies, the global strength of the evidence was low. There are only 2 studies, so it's not a very strong basis of evidence to begin with, and the 2 studies came to different conclusions. One study found some benefit from glucosamine, the other study did not. Now, if you look closely at the critical appraisal, the study that did not find benefit was actually a higher quality study in terms of the methodology and how it was performed. So we can draw the conclusion from this that the evidence is limited, but the best evidence seems to suggest that there was no benefit. Critically appraised topics, as I mentioned, are like mini systematic reviews. They ask very small, very focused questions. And something like, is oral glucosamine useful compared to an NSAID for arthritis, is a fairly focused question, so there are actually several critically appraised topic reviews on this. Now, these topics, just like systematic reviews, rely on finding and evaluating research in the primary literature. Since there are only 2 controlled clinical trials in the literature at the time all of these were written, that's what they rely on. So they do still have a relatively small, narrow evidence base. This one comes from a website called Best Bets for Vets. This is put together by the Center for Evidence-Based Veterinary Medicine at the University of Nottingham. Wonderful resource where they do critically appraised topics. I definitely suggest that you take a look at that. In this case, what they found was that looking at these 2 studies, carprofen was clearly superior to glucosamine and chondroitin, and unfortunately there was no study that compared glucosamine and chondroitin to placebo, to essentially no therapy at all. I actually published a critically appraised topic on this subject in 2010, quite a while ago, and the reason that I mention this is because it is always possible for you as a general practitioner to get involved in the production of synthetic evidence. If you have a subject that you're interested in, that you need to understand better for the benefit of a particular client, and you put a lot of time and energy into going to the literature and researching it, you should share that with the rest of us. Possible to publish a critically appraised topic. The RCVS, for example, has a place where people can go and has a structure and a formula all laid out for you. Now you can do your own critically appraised topic reviews. So if you get really excited about evidence-based medicine and about looking at the scientific literature to help you answer questions for your own patients, please be encouraged to share that with other clinicians because that makes the work easier for all of us. So I went through and looked at the same 2 studies that all of the other synthetic literature had looked at and essentially came to the same conclusion. Not much evidence, and what there was suggested that there was probably no significant benefit and that carprofen was certainly more effective. So the sum total of the synthetic literature that we have in veterinary medicine, which relies on a very small primary literature, is that there's not much evidence, and what there is suggests probably not great results from glucosamine. So we talked about using the human literature because there's going to be more of it and it's going to be better quality. So what happens if we do that with regard to this question? Obviously, we can't ask it for Labrador retrievers, but we can ask the general question, how does glucosamine chondroitin look to be doing for arthritis in humans? In this case, if you look for clinical practice guidelines, you'll find at least 15 of them. So again, huge compared to the 0 that we have available at the moment in veterinary medicine. The American Academy of Orthopedic Surgeons has produced one of these. They specifically recommend against glucosamine and chondroitin for osteoarthritis of the knee based on the fact that there have been extensive studies and it doesn't appear to be effective. The American College of Rheumatology, another specialist organization, has done a clinical practice guideline and also essentially says we conditionally recommend against glucosamine because it doesn't appear very effective. The OSAR is another international organization looking at research into therapies for osteoarthritis, and again, probably not appropriate for changing the disease, maybe or uncertain with regard to symptom benefit. Now let's look at systematic reviews in human medicine. Here we have 3 in veterinary medicine. We have over 90 systematic reviews of glucosamine chondroitin for osteoarthritis in humans. Now, the reason we have so many reviews is, as I mentioned, the human literature tends to be much more voluminous, and as a result, they tend to focus on much narrower subjects. So you can find systematic reviews of glucosamine for osteoarthritis of the hand, of the knee, of the shoulder, of the elbow, all considered different subjects. Whereas in veterinary medicine, we're likely to lump those together because we simply don't have enough research to make such fine distinctions. In general, if you look at those 90 systematic reviews, the conclusions are variable and the quality is pretty good, but for the most part, they all come to different conclusions based on how those reviews were done. So there's not a single overwhelming answer. The general trend is towards not much benefit from glucosamine chondroitin for arthritis, but there is some inconsistency. Then you go to the primary literature and look at those specific clinical trials. We've already talked about that. In this case, there are only 2 clinical trials looking at osteoarthritis treatment with glucosamine chondroitin, and those trials are mixed, one showing a benefit, one not. The one that showed no benefit was a slightly better quality trial. And then there's lots of preclinical research. This is not clinical trials comparing glucosamine to other therapies, but simply research giving glucosamine to dogs and seeing how it works, what its uptake is, what the side effects are, what effects on other organ systems might be, all of this research. This addresses the question of plausibility. Is it reasonable to think that glucosamine might be useful? And that preclinical research does suggest that there's a plausible theory for how glucosamine might be useful. And is it safe? The preclinical literature is pretty good in showing no significant adverse effects to glucosamine in dogs with arthritis. Then, of course, you can go to expert opinion or general opinion. You can ask 100 veterinarians and you will get many, many different answers. The reliability of that evidence is pretty low, and the evidence is not generally consistent. Even in my own career, I've gone from feeling like glucosamine was helpful to feeling like it's not helpful based on experiences with individual clients. But what I know from evidence-based medicine is that those experiences are not nearly as reliable as controlled clinical research. Okay, so we've gone through most of the process now. We've asked the question, we've found the evidence, we've looked at the value of that evidence and the limitations. Now we come to the core of our job, which is to draw a conclusion, to make a decision about what to do. So what's our option? Our option is we recommend glucosamine for Tallulah, or we recommend that the owner not use glucosamine. Those are options. We could recommend something else. We could offer an NSAID or some other therapy instead of glucosamine. We could not have an opinion. A lot of veterinarians feel like, their job is not to tell people what to do, but simply to offer advice. So we could say, there's not a lot of evidence, we're not clear, you can do it or not, it's up to you. Do we choose to sell glucosamine? Obviously, therapies that are effective are things we might want to offer to our clients and actually sell to our clients. And the question in this case is, do we have enough confidence in the literature to decide whether or not to sell this? What ultimately do we tell the client now that we've gone through the process of looking at the scientific research? So here's what I usually do. I start by saying, having thoroughly reviewed the evidence, I want the client to know that I have the expertise to find research evidence and the knowledge to look at that research evidence and think critically about it, and that I've done that work. I think it adds value to my recommendation for the client if they know that I've put the effort in to understand what the evidence says. So I say, having reviewed the evidence is fairly weak. So we don't have a lot of confidence in the evidence. There are only a couple of clinical studies. There doesn't appear to be much risk. Glucosamine and chondroitin are very, very safe. Okay? There's also not much reason to think there's going to be a significant benefit. In human medicine, it's generally not recommended because there doesn't appear to be much benefit. And in the clinical studies, one found a little bit of benefit. A slightly better study found none. It's not very expensive. So for the most part, I don't think it's going to be contraindicated for your dog. What I would say is, why don't we start with things that we are more likely to see benefits from? Why don't we start by having Tallulah lose a little bit of weight, because that can be very, very beneficial for dogs with arthritis. And if we feel like she's uncomfortable, if she's lame, or if I do a pain scale assessment and I think she has some pain, let's start her on an NSAID. I know that that's going to help her pain. If then you want to consider glucosamine because either you don't think those therapies are sufficient, you're not able to get her to lose weight, or she doesn't tolerate NSAIDs, we can certainly try glucosamine. We can add it on, or we can use it if we don't feel like she requires anything more aggressive or more reliable. But let's just do that in the context of this evidence. Now, one problem that comes up with veterinarians when I make a presentation like this and I talk about giving that nuanced advice to my clients is we hate uncertainty, and we think our clients hate uncertainty, and we feel like our clients expect us to have confident, solid recommendations for them. And so it makes veterinarians a little nervous to think about saying to clients, we don't really know the answer in this case. The evidence is not very strong. I'd like to try to reduce that anxiety a little bit for you if I can. There have been a couple of surveys asking clients, asking pet owners, how they feel when their veterinarian says, I don't know. I have to go look it up. I'm not sure. How they respond to expressions of uncertainty. And this particular survey found that most clients did not lose respect for their veterinarian or their veterinarian's recommendations. In fact, they were more confident in the advice they were getting because their veterinarian was honest with them and also clearly willing to do the work, clearly being conscientious about finding the right answer for their pet. So it seems like expressions of uncertainty don't necessarily undermine client confidence. This is another study at a tertiary oncology practice which asked clients about the information they got from veterinarians and what they wanted from that information. And a really key point here is the number one thing that all of the clients said is they wanted the information to be true. So if the truth is that we aren't sure, that we have very little evidence, that we're basing our recommendations on low-quality research or even on clinical experience alone, It's important to clients that they have that information. I think it helps inform the decisions they make, so it's part of our informed consent process. And I think we have an ethical obligation to be clear and explicit with clients about that. And that is what clients have said that they want from us. Here's a little guide that I like to offer for how to think about balancing the uncertainty in the evidence, which is often going to be there because the evidence is rarely strong and unequivocal in veterinary medicine, with the urgency of taking action. And this is a helpful way, I hope, to think about how we balance those things. So in some cases, the quality of the evidence is very high and very strong and very clear, and the clinical situation is very urgent. So if you have a dog with acute hemorrhage and in shock, there's clearly strong evidence that blood transfusion or that fluid administration is helpful and is appropriate, and it's clearly important that we take action because this is a life-threatening situation. That box is easy, right? Good quality evidence, clear what we should do, and very important that we act, easy to do. The other end of it is actually relatively easy for us as well. If the quality of the evidence is low, if we don't really know, but there's also not a really strong, urgent need to take action, sometimes it's relatively easy for us to recommend simply watching and monitoring. An example I like to use of this is tear staining, little white dogs that get that porphyrin staining on their face. It's often very disturbing to clients, but it's not a serious medical problem. It's purely cosmetic. There are a lot of products out there. There are herbal remedies, there are antibiotics, there are lots of things available out there to treat that, and there's very little evidence to say whether those things are safe or effective. This is, I think, for a situation where it's easy for me to say, I don't recommend these therapies because we don't know for sure if they're safe and effective, and frankly, it's not a really serious problem. If you have a show dog and you want to try some things, here's some things you can try, but the evidence is weak, and in general, I don't recommend it. Pretty easy. Here's a situation where sometimes it's not necessarily difficult to make a decision, but the decision could go either way. So in this case, the uncertainty is low, meaning that there's good quality evidence. We know what the right thing to do is. The urgency is also low. We're in a clinical situation where it's not really important. So we can take action or not based on what the evidence says, but it's not critical. So this is a fairly easy place to be in. This is the spot where our life gets difficult. This is a spot where there's something really important, either important medically to the patient or sometimes just important emotionally to the client. And it's urgent that we take action, but there's not good quality evidence as to what that action should be. And that's where I think we have the most difficulty practicing in an evidence-based way. And what I say to people is that the best we can do in this situation is communicate clearly and effectively with our clients. If we go through this evidence-based medicine process, if we understand what the evidence is and how much uncertainty there is there, we can communicate with clients effectively and say, it's important that we do something. Here are your options. Here's the level of confidence we can have in those options, and then let them make the choice. But we've given them a fully informed choice, and it's clear to them that we understand the evidence and that we're doing our work in a conscientious and judicious way. Okay, so in summary, what is it that you as a general practitioner should do in terms of practicing in an evidence-based way? I would say that you should try to be informed about the evidence. Go through this process every chance you get. Not, again, every day, all day long, because we don't have the time for that. But when you have recurring questions that your clients ask you, take some time every once in a while to look at those questions in this formal evidence-based way, find out what the research literature says, and just be aware of what that evidence is so that you can make more informed client recommendations. Think critically about evidence, recognize that some evidence is better than others, that clinical experience is very easy to come by when you've been in practice for a while, but isn't always that reliable, and that strong, high-quality synthetic research evidence like systematic reviews is really good quality, but not always available, and find the evidence and its level of confidence so that you can make informed decisions. Be explicit with your clients, with your colleagues about uncertainty, so when you're not sure, you can say you're not sure, but you can say you're not sure on the basis of a thorough understanding of the available information. And then share what you've learned. I think it's really important that if you go through this process, if you become an evidence-based practitioner in this way, that you consider contributing critically appraised topics or narrative reviews. These are very easy things for those of us in general practice without a lot of specialized academic expertise or training to do, but they make a huge difference in building a resource library for other veterinarians. Tell academics what you need. One of the biggest problems we have in veterinary medicine is that the evidence is often not applicable to real-world clinical problems because the things that you study as an academic or in research aren't always the things that are most clinically relevant. And so when you have a chance at these conferences to speak with academics, let them know what information you need. I would really love research to be expanded greatly in the area of symptomatic treatment of acute idiopathic diarrhea, because I see that all day long in practice, and we don't have a lot of good evidence-based therapies for that common problem. And then also tell industry what you need, because a lot of the funding and a lot of the research in veterinary medical science comes from industry. So when you're talking to people in the exhibit hall at a conference, go to them and say, I would love a product that is like what you have, but I really want this to be based on good evidence. So if you want me to use your product, I need you to do the research and show to me that it works in a good, sound, evidence-based way. Industry will be responsive to what their customers want, and if we ask for better evidence, they will give us better evidence. I hope this has been useful to you. Again, I hope that the online resources are accessible and useful as well, and I'm happy to answer any questions when we have the chance to do so. Thank you so much.